As Ricardo said, this is a very interesting case. This is a patient who presented to our hospital with decompensated heart failure. In fact, biventricular failure. He's 59-year-old, non-frail, independent, and he has a long life journey of valvular heart disease. In fact, the primary etiology is rheumatic valve disease, and he underwent 4 previous surgery with aortic and mitral valve replacement. The last one about 20 years ago, and now he's very symptomatic. The EUR score and the STS score are not so high. That's very interesting because this is a patient with multiple previous surgery. And these are the lab tests, as you can see, pretty normal, including renal function with GFR of 98. Liver evaluation was also normal. And as you can see here on echo, he has a preserved ejection fraction of the left ventricle, 59. He has aortic bioprosthesis dysfunction with severe aortic regurgitation. The mitral bioprosthesis is pretty normal with mild stenosis. But this patient has a massive tricuspid regurgitation. The pulmonary systolic pressure was estimated in 49 millimeters of mercury. And he has also a tricuspid annulus dilation, 49 millimeters. The right ventricular function is well preserved with ejection fraction of 52, a TAPSE of 17 millimeters. And we discussed this case in our heart team. And in summary, young patient, very symptomatic with multiple previous surgeries, and now with severe bioprosthetic aortic dysfunction and a massive tricuspid regurgitation.
Well, Dimitri, what a case. Can we have, please, the camera here with the operators, please? Okay, so you just presented a case. Rheumatic disease is still a problem of the daily basis in many parts of the world, and that happens also in Brazil, in Latin America. And this patient underwent 4 previous surgeries. Now it has a very dysfunctional aortic processes, and also a mechanism of dilated tricuspid valve, right, dysfunction,
Yeah.
and leading with a progressive worsening of its symptoms. So in a patient like this, in a situation like this, is surgery the first option of treatment? A 5th operation will be the first attempt to treat both valves?
Well, Ricardo, despite the scores, the STS and the EUR score 2, we consider this patient a very high-risk patient for reduced surgery with a high mortality. If we think of operating also the tricuspid, so it's going to be combined surgery, aortic, tricuspid, and probably the mitral, because it's the function is normal, but has some thickened leaflets and calcifications. So
It's a very borderline condition, right?
yeah, we deem that this patient is high risk with high mortality and higher rate of complications, for example, bleeding due to multiple adhesions of the chest. So it's a very tough case for surgery.
And from the percutaneous point of view, could we also offer possibility to treat the aortic dysfunction, prosthesis dysfunction, as well as tricuspid. And
Yeah.
in this case, what will come first? Because it's difficult to say, right? What's bringing this patient to a more adding more to the dysfunction that he's having in terms of the clinical
Yeah.
presentation right now?
That was our decision. We treated the aortic bioprosthesis dysfunction last week. We're gonna show you the images.
So the intention was to treat first, approach the aortic bioprosthesis dysfunction
Yeah.
with a TAVR,
Yeah.
and then following you could deal with the tricuspid.
It's feasible to perform both interventions at the same stage, but our decision is to first perform valve-in-valve, aortic valve-in-valve, and we did
To get some level of compensation, and then
we now we are gonna treat the tricuspid.
Okay, so what you did last week?
So may I have the slides again?
Okay, we have the slides here
so this patient, he has a BioCore 25 millimeters. So we decided for valve-in-valve with a self-expandable valve. We implanted Evolut R26. We did a post-dilation with a non-compliant balloon, and this was the result. With minimal peak gradient.
Just a great result, yeah.
And good angel.
Yeah, one question also. Is there any evidence or your own experience? You are have the one of the largest experience in Brazil, if not the most. In your experience, is there a preference for a self-expanding versus balloon expandable valve in a situation like this? Is there any scientific evidence?
It depends on the anatomy. I think in this case, maybe a balloon expandable valve could also work very well. The BioCore is 25, but if this patient has a smaller bioprosthesis, maybe a self-expandable valve could be a better indication for improved hemodynamics.
Okay, and we just came out from PCR, and we can say tricuspid was one of the hot topics there. Discussion. There's some no evidence and no trials, but what we see is still a very complex scenario, and there are some new devices. There's some recent evidence being presented. So, what are the options in a situation like this to deal with the tricuspid? You just showed a massive tricuspid regurgitation. What are the options in a patient like this?
I think that we have good solutions out there with multiple devices.
If you have the camera, please, again, operators.
We have the possibility of performing transcatheter edge-to-edge repair on the tricuspid with TriClip or Pascal. We have some
there's actually a study in PCR demonstrating, right? Our first randomized study.
Yeah, we have some dedicated transcatheter heart valves for tricuspid that are under investigation, but all the device has some anatomic restrictions.
Okay.
And this patient, for example, he has a huge gap on the tricuspid leaflets. The atrium are very enlarged.
So that's a limitation for some of these technologies, right?
So, and in Brazil, the only approved device for transcatheter solution for tricuspid is the TricValve.
Okay, okay. So show us what we have done so far.
So let me show here.
If you could show here, please, the groin here of the patient.
So we are going to perform this procedure under local anesthesia and conscious sedation.
No angel now, please, the operators, and the groin of the patient, please.
And we just got access here.
Okay.
Ultrasound guided venous puncture of the femoral vein.
Okay.
We already did a pre-closure with 1 ProGlide.
So the expectation is to use what size in terms of French size?
27 French.
And 1 pre-close is enough?
Yes.
Okay.
And on the left side, we got 2 access. Generally, we only need one, but in this particular patient, because of some anatomic characteristics,
Okay.
we're gonna put a pigtail on the pulmonary, right pulmonary artery, as you see on angio,
Okay.
and the other one, we're gonna put in the innominate vein.
Okay.
This patient has a large confluence of the superior vena cava to the right atrium.
Okay.
So we need to be cautious about positioning the superior vena cava valve.
Okay.
And we're gonna need some injections just to realize if this is a good position
Okay.
for the superior valve.
And you mentioned, Alberto, this will be approached as a minimalistic approach for this patient, for this gentleman. What does that mean exactly?
Yeah, the meaning is, thank you, Ricardo. We actually just
Can the
need,
operators too? Again, please,
we actually
operators.
just need the thoracic echo to guide us, because in the superior vena cava we have the landmarks to positioning the bioprosthesis, and in the inferior vena cava the thoracic echo
Yeah.
can help us to see the inferior vena cava and the right atrium.
Okay.
So it's enough to.
Okay. So, Dimitri, maybe you can see a little bit about this technology too?
Yeah.
Yeah. Can we have the slides back, please? Okay. So, I will ask Alberto to speak a little bit about the technology as you guys are working.
So it's a Bicaval valve system. It's made of two valves, one for the superior vena cava and another one to the inferior vena cava. So it's designed to treat the severe tricuspid regurgitation without touching the tricuspid valve. So I'll
That's
tell
why you call heterotopic, right?
that's at
Yeah.
the topic. So as you can see in the image, we have data with midterm follow-up that it avoid the backup flow, reduce the congestion, promote the right ventricular remodeling, increase the cardiac output, and reduces the symptomatic, especially
So
the right
this is the
ventricle
mechanism,
symptom.
right?
Yeah,
This is the
that's
mechanism. Okay.
So how do we select the patients? We have the clinical parameters to select the patients, especially the severe symptomatic with tricuspid regurgitation, with functional class of New York Heart Association 3 or 4, despite of the medical treatment.
Okay.
So by the hemodynamics, we can use the.
Can you show please the groin now? Yeah, please go ahead.
By the hemodynamics, we can use the vena cava, the atrium pressure of 15 millimeters. So let's continue here.
So Dimitri, what are you doing now, please? If you could just let us know.
We just placed a stiff wire on the superior vena cava. We're gonna use a Lunderquist wire, and we are dilating the axis here with a 18 French sheath.
So just preparing the room here to receive the larger delivery device, correct?
Yeah, that's
Okay.
perfect.
And you have the Lunderquist positioning, okay, and you control this by angel. Is there a need, Dimitri, to have like a echo guided procedure here? Or is it needed at every step of the procedure? Or you do it by angel and then is it more a control echo?
Yeah, for the superior vena cava valve, we don't see any benefit of having TE. Sometimes it's very difficult to visualize the superior vena cava. And we use the echo for positioning the inferior vena cava valve.
Okay, and we're going to be able to demonstrate that.
Yeah,
Okay.
but we can use the TTE to perform this evaluation. This patient has a good window, subcostal window, with good images. Sometimes it's not possible because of ascites or hepatomegaly, but in this patient it's feasible.
Okay. So now we could have here, please, the camera showing the device. Just showing the device, please.
A little bit upper.
We can show here.
So Alberto, can you please demonstrate? Can you have a zoom in the device?
Yes, of course. So
could demonstrate.
This is the superior vena cava device. It comes.
A zoom, please. A zoom.
So it comes pre-mounted with the dry leaflets. So it is not touched by the crimp. So it may reduce the infections. and it's easy to deliver the valve.
Can you just show here a little bit more towards the proximal part of this device? You're showing the distal. Just come to the proximal. We want to show the delivery system.
The other hand,
The
proximal
in the other
part
hand
of
here.
the proximal
From
part of
here
the
to
delivery
this
system.
side here. Bring the camera here, please.
Yeah, that's it.
Oh yeah, here we go. Yeah,
A little bit more. A little bit more. Go ahead.
Yeah, more.
Go more.
Yeah, here we go. Okay. Okay. Yeah, we can move a little bit here as well. Okay. Just bring to the camera. Okay.
So that's the delivery system.
Yeah, okay.
We
Okay,
have
good.
only one step, is to turn the wheel clockwise to deliver the prosthesis.
Yeah, perfect
So
now.
that's it.
Okay, so 27 French regiment. So you after you have the land acquisition position, you're ready to go.
Yeah.
Okay.
So based on CT measurements, we choose 25 valve, right?
25. Hold the wire, please.
Okay, so maybe we can have the angel in one side and our hands here in the other side.
So it comes very easy.
Okay, so it's going smoothly here. So Dimitri, can you? We already explained where this guiding these catheters are, but can you explain here what's the relation of this angiographic view and the catheters, the PEEK catheters? How does it help for the positioning here?
So as we said, we have a pigtail on the innominate vein and the other one on the right pulmonary artery. And we need to place this valve with the belly above the pulmonary artery catheter.
So the PEEK catheter here in the pulmonary vein, that's your marker there.
Yeah.
That's your landmark there.
Yeah.
Okay.
So I think it's a good point to start, right?
Okay. So you're comfortable here,
Yeah.
because you have like the belly, which is in the mid portion, just at that point. Which view do you use?
We are using posterior anterior view with no cranial caudal.
This is standard.
Angulations,
This
yeah.
is standard. Okay.
And Alberto is gonna start the release of the first valve.
Okay. So you can see here.
Yeah, it's a
Here
really,
so you're going clockwise.
yeah, with a really slow deployment.
Very slow. Very.
Yeah.
Dimitri, is there any worry that the device can move here
Yeah, it
as you
tends to
deliver?
move up.
Can still move up, okay.
Cranial.
So you have to keep some pressure
Yeah.
here down. Okay. So
Sometimes
you can see
we
the
need-
hands here. Okay.
Sometimes we need to correct the parallax of the valve.
Okay.
Let's see if
So
it's needed in this case.
can you, if you have a partial deployment, can you recapture and deploy again?
Sure. We
And-
can do it about 3 times,
Okay.
and we can recapture until 80% or 90%.
Oh, until 80 to 9%. Wow. So this is very helpful to achieve a precise and delivery.
Yeah.
That's correct. The parallax.
And
think so.
everything here just controlled by Angel. So you're doing it. So I start to see some flaring in the distal portion,
Yeah.
right? So that's how we start to see the partial deployment.
Yeah.
That's it.
Go ahead.
And you just align here about the parallax, right?
Yeah.
So that's helping you as well to
In
continue
this
the
case, we
delivery.
need to place the valve a little bit higher because, as I said, this patient has a larger confluence of the superior vena cava to the left atrium, to
Okay.
the right atrium, sorry.
Okay. So and that goes case by case, right?
Yeah. And
Let's do an angel here just to see the...
and the belly.
So you're gonna do a control angel. A recording. Okay, let's do it again. Okay, so
What do you think?
how do you like this position, Dimitri?
I think it's a good position. As I said, we need to put this valve in
Can you
this
just stop
patient a
here?
little
You
bit
can just
higher.
show the angio that you just did.
Sure.
Oops.
Next one.
Previous one.
Next one.
Previous.
Nope.
Previous. Okay.
Okay, so can you explain here for us the position here?
As you can see here, in fact, I think it's a little bit high now. Maybe we can pull the valve a little bit
And where do you want the belly exactly?
above the pigtail that is in the right pulmonary artery.
Okay, so you have some room there,
Yeah.
right? Okay.
Okay, go ahead.
So
Go ahead.
Alberto here is continuing to open. And it's nice, it goes slow, you can see the opening very smoothly. Now we see the belly in the mid portion. So when you say the size of this valve, is that related to the proximal, to the distal, to the belly, Dimitri?
To the belly,
To the belly,
point
okay.
of anchoring.
As
is
anchoring point,
the belly,
okay.
Yeah.
Okay.
A bit down.
So
We
now
need
you did another
oversizing.
angio. And okay, control angio again. So it's a little bit lower compared to the
Yeah.
previous one. So you like this position?
Yeah, I like it.
Okay, so you can just continue. In terms of the anticoagulation therapy for this treatment, Dimitri, is that the same as you do a regular PCI, or any considerations there?
Yes, we performed this procedure with full anticoagulation.
Okay.
We gave him 100 units per kilo.
Per kilogram, okay.
We are reaching the no
Okay.
capture.
So now you see the
point.
belly here, it's quite open.
So
And
let's take the pigtail off.
okay, so in terms of, I see you here, you pulling a little bit the pigtail. Why is that,
Yeah.
Dimitri?
Let's do another angel, and then we
Yeah.
are gonna pull out the pigtail.
Okay.
Just
So once you
not to be
confirm
jailed
you're
by
happy with the position, you pull back, you pull out the pigtail.
Yeah.
Okay. So no doesn't affect the stability of the device, which is good. And so Dimitri, now are you ready for full release?
Yeah. We
Okay.
are doing that.
So
As you
how
can
many
All the hooks
anchoring points you have there?
So as you can see here, all the hooks are already deployed.
You can see 3 of them.
The valve is free.
Okay, so 3 anchoring points here. Okay.
So, and now we need to pull the nose cone. This is
Okay.
a big
And
nose
what's the
cone.
technique there? Let's just move here a little bit more so you can demonstrate that.
Yeah,
That's
let's pull
important.
it very slowly. Sometimes we need to play with the wire,
Okay, just to make sure that you're not.
interacting with the prosthesis.
Yeah,
right?
yeah.
Very slowly, very slowly.
Okay, okay. And if you feel any resistance, you just push forward and then.
Yeah, and try again.
Try it. Okay, okay. So, and you leave the Landerquist in position there?
Yeah.
Okay, so.
So now we are ready for the inferior vena cava valve.
So
we're gonna
you just pull
leave
here.
the sheet here,
Okay.
and Mirella is gonna bring us the second valve.
Okay. So Dimitri, in the meantime, can you get back the slides just to
Yeah.
show how the imaging help us to size the device?
Yeah.
Can you have back the slides, please? Okay. Alberto, do you want to continue here?
Of course, where is the... So, as you could see there, the valve has the crown that you use the innominate vein to position the valve. And we have the belly that will be anchored the valve. And we have the leaflet working a little bit down. So as we did in this case, Dimitri told us the patient has an enlargement of the superior vena cava, so we placed the valve a little bit higher.
O MP, por favor.
Let's
MP.
continue. So for this case, we choose the 25 millimeters superior vena cava prosthesis,
Guia normal, por favor.
and that's the inferior vena cava prosthesis. The valve has the the valve functioning upper, and we have a skirt to minimize leak. But this skirt we have to put a little bit higher than the hepatic vein to not occluding the hepatic vein. I think that's it. As you can see there, we are going to place a catheter in the hepatic vein to use as a marker to deliver the valve. That's it. For the inferior vena cava, we choose the 35 one because of the measurements we did before.
Okay, very nice demonstration. So can we have the angel back, please? So now, Dimitri, you have partially removed the device, and where are you advancing this catheter, the MP catheter?
So we're gonna place the multipurpose catheter at the hepatic vein. We did some angel at the beginning just to show to you the anatomy.
Okay, so why do you need the catheter position there?
We're gonna need to place the inferior vena cava valve with the leaflets
Okay,
above the hepatic vein.
okay.
Not to. This patient has a huge hepatic vein.
So the
I think that
device-
the risk of occlusion here is low,
Okay.
but we need to place is a little bit higher than the origin of the hepatic
So
vein.
the distal prosthesis, you have the upper cells, open cells, to avoid the occlusion of the
Denominator
hepatic
vein.
vein.
Yeah.
Yeah, okay.
So we are ready for the second valve?
Yeah, we have to. Do you have already closed?
Yes, yes.
Yes. So
So we have closed already here. That's you can lock here the system to bring it back. And now we're gonna go for the distal. So
push.
Going.
they're just removing, and we have the distal valve, sorry, the inferior valve already in place. So any considerations here, Alberto, about the distal?
So that's the inferior vena cava system.
You wanna show,
It's quite the same of
same
the superior
appearance?
vena cava, and the way to deliver it's the same.
Okay. So
We just need to check if there any gap here
Yeah.
with the nose cone and the sheath.
Let's close a little bit more.
just to make sure, okay. So we're advancing here. The IVC processes now. Again, everything guided here by angel. So you don't need the pigtails anymore. You just need the catheter, the multipurpose catheter position at the hepatic vein.
Yeah.
And
And
Dimitri,
now, Ricardo, the echo is going to be very important.
Okay.
Just to
Dimitri,
visualize.
I
if
do
there
see
is-
by angel some crowns here in the cell, some levels. Can you explain to us what we are seeing here?
Yeah.
Yeah,
Alberto,
you
yeah.
can see a light band there. When you have the transition between the skirt and the valve and the frame of the THV, we have this marker. So that's we used to.
That's a transition there.
Yeah,
Okay,
transition.
that's a marker. Okay, so Tito, can we have the echo, please?
Yeah,
Live.
It's
So
here.
Tito Palladino, welcome Tito. It's great to have you here.
Thank you, Richard.
A lot of experience with this guiding these procedures from the echo department. What you're showing,
Alton.
please, and
mais
also
alto, né?
the
Transição.
position of the valve.
actually, we just need to analyze the IVC here and the hepatic vein, just to avoid the obstruction of that. We did some previous image here, just to analyze the anatomy, and that's okay. We have a distance something around 12 millimeters. And now we just need to see where to put the process, you know.
The goal here, Ricardo, is to minimize the protrusion of the valve inside the right atrium, up to 8 to 10 millimeters.
Okay, maximum 8 to 10 millimeters. So I was just wondering here, if a patient has a pacemaker, is this a problem to deploy this device? Is this a limitation?
I don't think so. I think this is an
Like a permanent
advantage
pacemaker?
of the device. There's no interaction with the leads. Obviously, we measure the parameters of pacemaker before and after TricValve implantation, but generally this is not a problem.
Okay.
Tito, can you see for us the positioning in the right atrium?
Maybe too high a little bit?
It's a little bit inside the right atrium.
Yeah.
Yeah, we are pushing.
So it was a bit too high, so now we're moving
Pull some.
more towards the lower part. So Tito, you want to show us here, tell us exactly what you're seeing there, and maybe to appoint this to the ones who are following us here in this procedure?
We are seeing here the process in the catheter. So we just need to show them the distance that we are inside the right atrium, just to find a great distance for them, something around 8 and 10 millimeters from the origin of that.
Okay. So Dimitri, here at this point, you also need to keep
Some tension. on
some
the
tension,
system, yeah.
okay? Pulling back to some extent.
Let's do an angel here. Just see the.
Okay, so that's an angel here. You want to stop the angel, Alberto, and tell us what you saw and how's your reaction to this position? Just okay. Yeah, you just stop there. So
as you can see, the hepatic vein is drained to the inferior vena cava. We have the open cells region marked by the light bands.
okay,
So I think we are good to keep going.
Go ahead.
okay.
Slowly.
So
slowly,
now you're opening.
slowly.
You see the flaring of the.
Maybe Tito can tell us
Just
about the
Tito,
positioning.
what about
Yeah.
the position? Can you
I
show
think
us there?
that's okay. It's inside the right atrium, something about
So
5
I need
millimeters.
now,
just
the
that.
5
angel
millimeters.
and the echo side by side. Angel and echo side by side. Let's just go slower here to demonstrate.
So you said 5 millimeters?
5 millimeters.
Okay,
It's a good
perfect.
place.
No, I need the echo. I need the angel and the echo. Just
going-
side by
Go
side.
ahead,
That's
very
important.
slowly, very slowly. Slowly. Slowly.
Can we have the echo, please?
Do an angel.
Okay.
We wanted to see.
Let's do another
We want to
angel
see
here.
the angel and the echo side. Okay, great.
Here is the
Thank you.
process.
Okay.
Okay,
I think it's fine.
Dimitri,
Right.
can you tell us what you just saw? Did you just get back here?
Bem local.
Okay, so
So you can see that the upper part of the valve is above the hepatic vein.
okay, Chito, can you demonstrate that too?
Yeah.
Just side by side here, the angel and the echo, just to try to see very didactic here.
Yeah, as you can see here, just inside the right atrium, just a small amount of the processes, and a little bit in the ostium of the hepatic vein without any problem.
Yeah.
It
So
doesn't.
Dimitri, here you in this position, you feel comfortable, just continue to release,
Yeah.
control by echo, control by angel, and also
You can notice, Ricardo, that we pull the wire
yes, I did
also
see, yeah.
because if there is some angulation with the superior and the inferior vena cava, you can have some
That will not affect,
difficult-
right?
Yeah.
Yeah, you can cause some, yeah,
Go ahead.
you can be too protruded, right?
Yeah.
Because of the angulation.
Go
So
ahead. Go.
you are continuing here.
We don't need to
The
correct
release.
the parallax.
So we do see a belly here as well in the
No,
in the inferior
No,
one.
no,
No,
no.
it's more in the proximal one. And as you pointed, Alberto, just the transition there
Yeah.
is exactly
Open
well-
cells to closed cells.
open to closed cells. So
Let's do an angel
that's
here.
your marker there. So we're gonna do another control angel.
It's
So Dimitri, do you feel comfortable here?
Yeah.
If you need to recapture here at this point, could you do
we
it?
can.
Yeah.
You can do it
Can.
and just reposition.
we can recapture until 80% of the delivery.
Okay, Chito, anything you want to point out there?
No, for me that's okay. It's the right place here.
Go ahead.
Okay.
Slowly.
So slow.
Oh, it's
And you also keep pulling a little
I'm
bit,
keep
right,
pulling,
Dimitri?
keep pulling.
All the time. So
Yeah.
that's very important.
Chito, can you take
Chito, can you
a
just
little
remove the
minute?
probe a little bit?
okay.
So,
Slow,
okay.
very
Thank
slowly.
you.
Stop here,
So,
stop here.
yeah, very slowly.
Yeah. Go
Okay,
ahead,
so,
open lid.
Agora só aqui.
Dimitri, if we can just stop a
mais.
little bit here. For me, it appears to be a perfect position, right?
Yeah.
Just perfect, right?
Yeah.
You see the upper open cells just at the level of the hepatic
Go
vein.
ahead, go
You
ahead.
see a transition and you see the closed cells
Yeah.
just distal to the level. So you are safe
So-
here.
Yeah, so let's measure again by echo. Just to
Okay,
see.
so
Okay.
now Chito is going back with the probe there to see. And Tito, can you just point out, do you do some measures there, Tito, or it's just a visual assessment?
First of all, is the visual assessment. Then I can measure just the protruding part of the prosthesis.
Can you measure there for us to show?
Yeah, of course.
Yeah, because I think that's,
Oh, we can see here just the tip of the prosthesis, 80 millimeters inside the right atrial.
so Dimitri, you said about 8 to 10
Yeah.
millimeters, right? So just
Yeah.
8,
Maybe a little.
very precise, perfect positioning.
Go ahead,
Yeah.
Yeah, hand.
go ahead.
And we can see an obstruction of the hepatic veins. Regular
Okay.
flow.
Okay,
That's okay.
so Alberto is continuing here. You just released, right, Alberto?
Yeah.
Yeah.
So it's fully relieved. You remove the multi-purpose catheter. So Dimitri, at this point, is the procedure is done?
Yeah, let's see on echo. There's some a little bit of pop-up during the final release.
Okay.
Let's see the result by echo if there is any paravalvular leak or any other issue.
So in case there is a paravalvular leak, what is recommended at this point? Does it make sense to consider balloon inflation
no,
there?
No, I don't think so. We don't have a good experience with balloon expandable valve in the inferior and superior vena cava. We wait for some minutes just the valve to expand more.
Because it's a nitinol, there's a
Yeah.
memory, right? So you'd expect that to accommodate, right,
and
over
if
time.
if needed, we can put another valve, but I don't think it's the case.
Okay.
Right, Tito?
So Tito, can you want to show us here and point it out? What you see there?
As you can hear, first of all, the hepatic vein is a regular flow, nothing, no problems there. We can see a small paravalvular leak. I can point here in the screen.
So let me
At
remove,
this position.
So Tito, me remove the guide wire.
Okay.
So removing here the nose cone is the same care, right? As
Yeah.
you did in the upper processes.
Tira o guia também. Deixa. Vou subir com o pig depois, né?
Okay, so Dimitri being very careful here to make sure that's coming freely, right,
Yeah.
Dimitri?
Yeah.
That's what you want.
So let's do it. Let's
So
see the echo right now.
You want to show here just how to remove. Can I have now the hands here of the operators just to show the
handle.
removal? Alberto, you want to demonstrate here? How do you prepare here to remove?
Yes, of course. The camera is already
Can I
here.
have zoom here, please?
Yeah.
So
Great.
the same wheel we use to deploy the valve has a lock and unlock button. We
Okay.
have to unlock the valve,
So you just unlock.
just unlock, and then we see in the angel.
Can you see the angel, please? Now, angel.
No.
Can you see the angel? Instead of echo, we want the angel. Okay, you can show now live. So what you're doing here, basically?
We are pulling here, close.
Okay, so you're putting that in the previous position, right?
And then
To remove
we close it
before
again.
release. And
Yeah.
now
Oh, that's it.
you're locking the system. Okay, so now it's ready to remove.
let's do some measure here. And let's see the echo first.
Okay, can you have the echo? Okay, echo is there.
Dá um guia, por
Tito,
favor.
Hmm?
Um guia.
Well, here we can see the whole process now. Something around 8 millimeters inside the right atrial. And a small paravalvular leak here, as you can see in the screen. I can show you with this
Colocar um
arrow
pigtail.
here.
Colocar só para medir a pressão com pigtail.
As you can see
Can you
here,
show
this
pig
flow.
Yeah.
But the hepatic vein is the preserved flow and
Bom aqui?
nothing
Esse é o MP.
after this
Medir a pressão.
paravalvular leak.
Do you think it's small paravalvular leak?
Yeah, it's a mild one.
Mm-hmm. And it ended 8 millimeters inside the right atrium,
Yeah.
or a little bit more.
Let me see here.
Good, right?
So
Actually, it's a little bit more, Dimitri.
mhm,
13 inside there.
13. Okay.
Okay.
I think in the final release it moved up a little bit,
Okay.
but I think
But I
it's
think
a
it's still
very
yeah,
reasonable
yeah,
result.
Yeah, reasonable position, yeah.
Maybe it's
So let's see
slide.
the hemodynamics. Deixa eu colocar a escala de 50 para mim.
Can you show please the pressures, the hemodynamics? Can we see
So-
the pressure? Okay.
Okay.
We're still not seeing it. Okay. There you
So
go.
here you can see huge V wave, right? We are with the catheter in the right atrium. So let's pull back this catheter here
Moderate.
just to see.
Uh-huh. Yeah. So it's
I think it's a very
nicely demonstrated. So Dimitri, from the physiological point of view, what do you? We still have here 9 minutes to go. What do you expect to happen immediately? You just demonstrated now here the hemodynamics.
Mhm.
What's the effect of this treatment?
So first of all, we don't
this
have
point.
any significant backflow to the hepatic veins as we
Yeah.
can see on the hemodynamics, just a mild paravalvular leak. We don't expect to see any change in tricuspid regurgitation right now. And there is some evidence that at medium term you can have a positive RV remodeling with smaller tricuspid.
So this has been
after
demonstrated, right?
follow-up, yeah.
Has been demonstrated. And
But
it-
the biggest impact on patients is quality of life. We can, in our experience, we can reduce the dose of diuretics and to diminish the need for admissions in the hospital
and is this
improve-
already in the short term, or
yeah,
that takes some
definitely.
time?
Yeah,
So it keeps
definitely.
improving.
yeah.
Okay, so Alberto, it's impressive to see this technology, very unique and singular technology. More than 1,000 patients already treated worldwide, and I heard that the first patients in India, they already have follow-up of 5 years. So based on, we're building our experience here at Dante Pazanese with this technology and offering this for very complex patients like this patient that at the end of the day, they have very few options for treatment, right?
Yeah.
So what could you say about the clinical follow-up of these patients and a case that has decompensated cardiac heart failure? What would you expect in the short term and long term?
As Dimitri said to you, our patients that we treated with the TricValve,
Can we have here the operators now,
we-
please?
we saw the reduction of the diuretic need to the half, and we see improvement to the life quality. The patient that was functional class 3 or 4, now they are 1 or 2. So it's pretty impressive.
Okay.
And we can see as well the improvement of the renal function.
Can we
when you
have the camera and the operators, please, to discuss our faces here?
So the short-term results are quite good.
Okay. And another. Okay, so we have everybody here. So Michelle now she's doing
Yeah, we just
the
closed
compression. She's going
the
to
groin.
close. Okay, so very I would say straightforward. Smooth procedure. Patient, it's only under sedation, right?
Yeah.
And I think
Post-procedure care is going to be
Post-procedure.
simple.
is that
This
1-2 day hospital?
This patient
Maybe
is
the
going to
same
be
day.
at our recovery room for about 3 to 4 hours,
Okay.
and then to the ward, and maybe tomorrow another TTE just to see the result if there is some reduction of the paravalvular leak, and probably tomorrow he's going to be discharged.
In the institutional protocol, do you recommend a follow-up? You mentioned tomorrow to do a control echo, and then you do in what 30 days another echo?
Our protocol is to have another visit at 30 days with clinical and echocardiograph follow-up. This patient is going to be anticoagulated with warfarin.
For how long?
For maybe long term. We don't have the data
You still don't have the answer for that.
but
Yeah.
maybe,
So long term, the patient keeps on that. Yeah. What kind of anticoagulator? The new ones?
It's probably safe to use DOAC, but we don't have data out there.
We still don't have data. Okay. The
But,
data is being
our
built.
preference is to prescribe warfarin.
Okay. Okay. And I was going to ask you and Alberto, what are the complications that might occur and what are the rates? It appears to be a very safe and truncated procedure, but you highlighted very nicely about all the anatomic considerations, and you need to have the right conditions to have a good and optimal implant. So can you tell us a little bit of what potential complications and the rates?
Well, complications rate is very low. Huge complications like, for example,
like embolization
is very rare.
Okay.
And in our patient, that's what is described is some patients complain about right shoulder pain.
And why is that?
This is a neuropathic manifestation because of the inferior vena cava, oversizing device in the inferior vena cava, and this can persist for some days, 1 or 2 days. It resolves with gabapentin. We prescribe here at Dante this kind of medication to prevent this right shoulder pain.
Okay. And one thing we already discussed during the procedure, but I want to get back because a lot of these patients, they might have this situation, is about pacemaker, permanent pacemaker, or they might need a pacemaker, right? And then there's the lead, which is in position in the right ventricle. How does that interact with this procedure and with this device?
You mean if the patient needs pacemaker after the TricValve?
Yes.
I think this is not a problem unless the operator use the left venous system, because the innominate vein is jailed by the superior vena cava, but we can use the right venous system. And for endomyocardial biopsy, I mean, it's possible to do it with careful manipulation of the catheters inside the valves.
Okay. All right. So Alberto, one last question about these devices. You mentioned about the sizing. Are there patients that potentially could benefit by this technology but still don't have the right size? Is this a reality? Or most of the patients, they could fit on what is available now?
We have patients that has larger anatomy that we cannot reach with the device available now.
Okay.
So there are patients that we cannot treat with the TricValve.
And what are the options for these patients?
So it depends on the anatomy of the patient. If he has the enlargement of the tricuspid, the clip, the tri-clip or the Pascal device would not be an option as well. So we have to wait for more dedicated device for tricuspid regurgitation. We have no available here in Brazil, but we know that has some studies going on.
Okay. So Dimitri, I think this was a great demonstration. Congratulations for you, Alberto, for the whole team and all the nursing, all the assistants, for the team from TricValve. They are here assisting us with Tito. I think it was a very, very elegant demonstration about this technology. And it's amazing to see a patient with 4 previous surgeries with such a complex clinical condition, with the aortic bioprosthetic dysfunction, and also this massive mitral regurgitation I pointed out, to receive treatment, percutaneous treatments with TAVR, successfully done last week, and now with TricValve, with all the potential to have a good clinical follow-up. So I think that speaks for how much we have advanced and what we can offer for very complex patients for their benefit. So thank you so much on behalf of the whole team, the Cath Lab, our director, Dr. Fausto Ferris, for this live transmission. We hope to be back with you next week. It's a great pleasure to participate with you. And we wish you a successful continuing of the cases throughout the day. Thank you.
Thank you.
Bye-bye.